Hello and welcome to this OncLive peer exchange panel discussion which will explore treatment advances for metastatic melanoma. The tools we have available for treating patients with advanced metastatic melanoma continue to expand, as do the data to help us use novel therapies in more effective ways than ever before. Today, I'm joined by an international panel of experts in melanoma clinical research. We will discuss the latest data from studies related to the management of this disease, including ones from ESMO 2018 annual meeting in Munich. And we will provide perspective on how you can apply these new data to individualized treatment strategies for your own patients. My name is Axel Hauschild. I'm a professor of dermatology at the University of Kiel in Germany. Joining me on this distinguished panel are global experts in melanoma. It's Dr. Michael Davis, Associate Professor and Deputy Chairman, Department of Melanoma, Medical Oncology at the University of Texas MD Anderson Cancer Center in Houston, Texas. It's Dr. Jason Luke, an Assistant Professor of Medicine and Medical Oncologist at the University of Chicago, Medicine in Chicago, Illinois. It's Dr. Caroline Robert, Professor and Chairman of the Gustave Roussy Dermatology Center in Paris, France. And last but not least, Dr. Merrick Ross, the Chief of Melanoma Section and Professor in the Department of Surgical Oncology, Division of Surgery at the University of Texas, MD Anderson Cancer Center in Houston, Texas. Thank you so much for joining us. Let's begin our discussion now. So in the first part, we want to discuss a perioperative therapy. And the question is how we manage melanoma in the earlier stages, which means how are we managing primary tumors? What is the safety margin? Is there an agreement on this? And how we will manage the sentinel node biopsy? And if the sentinel node biopsy is positive, what are we doing with the patients? Do we need a completion of lymphadenectomy, yes or no? So the first question is for Caroline, do we have any international accepted rules for safety margins for primary melanomas?
Yes, I think now we are quite agreeing. We know that we don't need to do this huge margin that we were doing years ago, and it's very rare that we take more than 2 centimeters of skin around the scar or the melanoma. And we also know that this surgery of the primary is mostly here to decrease the risk of local metastasis. So we also have to integrate that in the particular cases of very old people where it's difficult to do a large excision. Now, concerning the sentinel node, we have some information now that positive sentinel node do not oblige us to do a completion of the lymphadenectomy because we know that it doesn't change the overall survival. And I think progressively the teams are modifying their habits. For example, I can tell you what we do. We explain we still perform sentinel node biopsy for melanoma thicker 1 millimeter or thicker than 1 millimeter. And depending of the type of metastasis that we find, usually we do not propose a completion of lymph node dissection afterwards. But we also take into consideration the fact that the patient is or is not going to be able to have a good follow-up with ultrasound. Imagine a person who lives far away or somebody who is not compliant, then it might be different. So I think it's still very important to consider individually the patient that we take care of.
So can we conclude here on the table that there's internationally accepted rules for safety margins of the primary tumor, which is a maximum of 2 centimeters nowadays? Is there an agreement here on the table?
Sure, but I also think we're also diagnosing melanoma earlier than we used to. So we can even use, a lot of times, just 1 centimeter margins.
Yeah.
Like, for example, pretty much melanomas up to 2 millimeters in thickness, we would normally recommend 1 centimeter margins. And for melanomas that were thicker than that, then we would consider the 2 centimeter margins. But it needs to be understood that in certain anatomic areas where there's restriction, like, for example, on the face, if the lesion is close to the mouth, the nose, or the eye, or in these critical structures, that you can adjust your margins appropriately so we don't cause undue morbidity to the patient.
And Jason, there is a consensus on doing the sentinel node biopsy, but it's widely accepted as a sort of a staging tool, but not as a therapeutic procedure with the attempt to increase the cure rate. Would you agree on this, or how is it done in your center?
Absolutely. I think that this has been an area really of a lot of transition in melanoma as well as breast cancer and other tumors recently. But with the publication of MSLT2 showing a lack of an overall survival benefit in the vast majority of patients, we really no longer prioritize doing completion lymph node dissections. That being said, sentinel lymph node biopsy is still the standard of care, and I think it's important to point that out because even in our area, some dermatologists are even talking about not doing sentinel lymph node biopsies. But for the purposes of our medical oncology therapies after surgery, we absolutely need to have them now because they stratify standard of care therapy. As to whether or not over into the future, we may have paradigms that have even less surgery, I think that's an open question, but certainly right now the standard of care is to do a sentinel lymph node biopsy on any patient with a 1 millimeter, perhaps in the US even slightly less, a slightly even less thick melanoma down to maybe 0.7 with high risk features.
Yeah, it's the same in Germany, so we are doing it in patients in general with more than 1 millimeter tumor thickness, but if there's additional factors like ulceration, which plays a role, we are going down to 0.7 millimeters.